Good afternoon, everyone. We will call to order the Treatment and Recovery Subcommittee meeting. This is a subcommittee of the statewide Substance Use Response Working Group. Our next item of business is to establish quorum, so I will turn it over to Kelly to do our roll call.
Thank you, Chair Shell. Chelsea Cheatham.
Here.
Dr. Dixon.
Here.
Steve Shell.
Here.
Jeffrey Iverson. Dorothy Edwards.
Here.
Mr. Chair, we have a quorum.
Great. Thank you, Kelly. Item number 2 on our agenda is public comment. This is for discussion only. Please bear with me as I read a brief statement. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241020. So on that note, Kelly, do you see anyone wishing to make public comment today?
Kelly, this is Dorothy. I'd like to make a public comment.
Yes, please, Dorothy. Hello.
Okay. Hi. I will submit this in a more of official way, but just for the purposes of the minutes, Dorothy Edwards for the record, I will be retiring effective September 30th after 31 years of public service, and so will not remain, of course, on the SURG committee, which has been my greatest honor to serve. I would like to take part until September. I've talked to Dr. Kearns about that. But, you know, should we need to fill my spot sooner or, you know, start discussions, I wanted to certainly do that for the sake of the committee. So that is it. And I'll submit a letter, Kelly, up through the appropriate channels.
Dorothy, thank you for sharing that information. We applaud you for your many years of service.
Thank you.
We all know you've done a phenomenal job for the state of Nevada and Washoe County and supporting all of us. So we just appreciate you for everything. So don't really want to have to hear that you're retiring, but
well, thank you so much.
Yeah.
I appreciate it.
Thank you, Dorothy. Do we have anyone else, Kelly, wishing to make public comment?
I do not see anyone. Laura, do you see anyone else with public comment?
No.
Oh, thank you.
Okay, thank you. So that will conclude public comment. We'll move on to item number 3 in our agenda. This is a review and approval of minutes from our March 18th, 2025 Treatment and Recovery Subcommittee meeting. Hopefully all of our committee members have had a chance to review the minutes. And if so, we can entertain a motion to approve.
This is Dr. Dixon. I'll move to approve.
Thank you, Dr. Dixon. Do we have a second?
I'll second, Dorothy.
Thank you, Dorothy. Do we have any discussion regarding the minutes for March 18th? Hearing none, all those in favor, please say aye.
Aye.
Aye. Any opposed? Motion carries unanimously. Thank you. Moving on to item number 4 in our agenda. We're very excited to have Dr. Jose Maria Pardita Corona of the Pardita Corona Medical Center with us today to present on trends and opportunities related to substance misuse treatment. So very excited to have Dr. Jose here. So I will turn it over to the doctor. Hello, doctor.
Hi, thank you.
Hello.
The presentation that you have there is that my presentation? Okay, there we go.
Okay.
Okay, I just wanted to make sure there. 1 second. So what I wanted to speak to the SURG committee on, well, for starters, allow me to introduce myself, Dr. Partita Corona. I'm board certified internist and addiction specialist. I was actually the the graduating class, the inaugural graduating class of the Southern Hills Fellowship Program that started a few years ago. Since then, I've been working with the fellows that have come after me, providing them with an ambulatory clinic site for their edification. As far as, could you move on to the next slide? So that's actually one of my disclosures there, that I do work with the fellowship program. I do own my own clinic, and at my clinic, I've dealt with patients with substance use disorder, in particular opioid use disorder, since about 2010. That's actually one of the reasons why I went ahead and did the fellowship program. I also have founded Amparo, which is a nonprofit the entity that we're trying to get over to a federally qualified health center. We're trying to convert it to a federally qualified health center, and that will be aimed towards treating folks that are in addiction, both with their primary care needs and their medication-assisted treatment needs. So how can we best utilize our current resources to affect change in the morbidity of opioid use disorder? We have recently been doing quite a bit of introduction of naloxone into the community. In fact, I'm sure the SURG committee is aware of the trends that we've seen nationally, unfortunately not here in Nevada, but nationally we've seen the trend of a decrease in the morbidity associated with opioid use disorder. And in large part, we have concluded that that is from the distribution of naloxone, as well as lowering the bar to the treatment in our community. That we did by changing the guidelines for the X waiver. I'm not sure if all of you are familiar with what the X waiver is and what it intoned. But basically, you had to have specialized training. It was really just, I believe, an 8-hour course to prescribe Suboxone. And so that limited the number of primary care physicians and other physicians that would write Suboxone. Fortunately, they've gotten rid of that waiver. And so now any physician can actually write for Suboxone. So that has decreased the bar to some extent as far as allowing treatment. We did also open up to NPs and PAs, so that also helped. We can initiate treatment in the field, which actually Kelly Morgan is kind of heading that up in our neck of the woods, and she's doing a fabulous job of it. Where hopefully we'll have soon Suboxone available in certain situations on the rigs in the community. And the last one, we can utilize the contact opportunities we are given to direct those with substance use disorders to affect real change in their usage. Now, on that point, really, if you think about it, there's two situations in which people tend to make life-changing decisions, okay? One of them is when they're incarcerated, right? Because, you know, all of a sudden your life is on hold for however long you have to sit there in jail or prison. Fortunately, with the American Disabilities Act and the enforcement thereof, we've seen an increase in the availability of medication-assisted treatment in the incarcerated setting. Actually, Kate Jessup, my missus, actually, started the Clark County Detention Center MAP program under WellPath, and now it's under NavCare. But it's slowly but surely been increasing since February of last year. I believe they're sitting around between 160 and 180 and that's their daily census of patients, which I think is phenomenal given the fact that it's a jail, and so there's quite a bit of turnover in that jail. But that also speaks to the need. Now, the other place that we can affect change is when these patients overdose. And when they overdose, sure, the rigs get to them, but they also end up in the hospital. And that's the key point that I want to drive home, is that in the hospitals, to a large extent, we are not doing nearly enough of what we need to do. If you would, next slide. Okay, so like I said, hospitals present a unique opportunity. There's currently bridge programs, 268 acute care California hospitals facilitate addiction treatment in a hospital. Okay, currently here in Nevada, we have to some extent UMC, and definitely at Southern Hills Hospital because we have the fellowship program there. But that's it as far as I could find. And of those, the only hospital that I know has delineation of privileges is Southern Hills Hospital. If you would, go ahead and move to the next slide. Okay, well, there we go. So here, what are we facing in Las Vegas? Keep going. So there's only currently one addiction medicine fellowship program in existence in Nevada, and that's at Southern Hills. We only graduate 1 to 2 fellows per year. Keep going. We have less than 0.1 addiction certified psychiatrists per 100,000, at least according to every research that I can do. Of all our hospitals in Nevada, only Southern Hills Hospital has adopted a delineation of privileges. None have credentialed guidelines for addiction mid-levels or for peer recovery navigators. And this last point is important, that although overdose death rates in the United States has dropped 27% from 114,000 to 87,000 from 2023 to 2024, during that same time, we had an increase in Nevada. And that is very problematic because I think we're one of 2 states, or I guess a few more states there, but we're in the red, and I think we're the worst in the red out of all of them. Go ahead to the next slide. So addressing the gaps in the hospital can benefit all the special groups that we worry about, whether they be incarcerated, the youth, so on and so forth, because they all end up in the hospital. Well, I shouldn't say they all end up in the hospital, but the vast majority of them end up in the hospital should they overdose. And you know, that's the other situation in which people tend to be very motivated to make very life-changing steps to rehabilitate. And next slide. So several things that we can do. Addiction consult services, that basically provides a warm handoff to outpatient rehab. It can facilitate better care of patients for other substances such as alcohol. And actually, alcohol is one of those things that we really manage poorly in hospital when we don't have folks that are trained in addiction. Another situation, patients that have like heart valve issues from IV drug use. A lot of times we're a lot more successful in preventing those surgeries from being in vain when we can actually get them into treatment as well. Therein, we can save quite a bit of money for the healthcare system as a whole if we can actually get these patients treated for their addiction, and we manage to save life. And it building up addiction service in hospital will also allow us to build a deeper bench of addiction specialists in the community, because by having addiction consult services throughout the hospitals in Las Vegas, we can provide basically jobs for these fellows that were graduating. Otherwise, they're going to go elsewhere. And peer recovery navigators, if we get them to the hospital, we can help reduce the stigma. And by helping reduce the stigma, it makes for better success rate as far as approaching those patients to perhaps get into treatment and eventually recovery. And adopting a delineation of privileges. You guys can read all these if you haven't already, but the important point here, I believe, especially in light of what's going on with the federal government and everyone wondering whether or not grants are going to continue and so forth, is the bottom point here, is that by adopting delineation of privileges, it provides funding for treatment of substance use disorder by allowing billing. You see, when you go to the hospital and you're under a hospitalist care, the hospitalist gets paid. But when he calls a consult, say cardiology or nephrology, all those consults have a delineation of privileges as specialists. And it's that delineation of privileges that allows them to bill insurances for the services that they provide. So because we don't have these delineation of privileges for addiction yet in the hospital, those services by necessity or by default have to be supported by grant money, which is becoming ever so much more scarce. So by adopting these delineation of privileges, you open up the opportunity for these services to be supported by something other than grant services. I mean, other than grant funds, so that you can treat it like you should, like any other specialty. And if you consider that we've lost 100,000 in the past years, that's right up there with some of our most common diseases. So how we can not have this as an option in hospitals is just unfathomable to me. So next one here. Let's see. These are the different studies that basically were done that show why we should do these things. So the START program basically showed that there was a much higher incidence of folks that had substance use disorders seeking treatment afterwards when they interacted with addiction consult services. And it also didn't just mean that they were more likely to start medication-assisted treatment in hospital, but they were also more likely to continue that after they were discharged. The SUN study that basically showed the value of peer recovery in the hospital, in particularly in the ER setting, which is really the best place for these peer recovery navigators to be. Now, there's a debate in the addiction world whether or not those peer recovery navigators should be tied to a hospital or should be tied to a particular insurance. Me personally, I think the best way for peer recovery navigators to be incorporated into the whole hospital system is to have them tied into a addiction service, and hopefully a Pan Valley addiction consult service, so that we can get more bang for our buck, basically. Let's say you had initially a peer recovery navigator that wasn't just covering UMC but Valley as well, so they could go back and forth between the two hospitals and initiate treatment for these folks regardless, because they're tied to a consult service rather than a hospital. That said, the hospital still needs to find a way to credential. And that bottom one is just a letter that ASAM, which I'm part of, as I am the committee chair for public advocacy for Nevada SAM, but ASAM is our national chapter, if you will. So they put out a letter basically saying how important delineation of privileges is as well. And next slide, if you would. So my recommendations are as follows. One, we honestly need to fund more addiction fellowship slots and start more fellowship programs. I believe there's one that may be starting up in Reno, from what I understand. Oh, can you move back to the previous slide? We could probably use another one here, or more slots in the program that we currently have. Require any Nevada hospital receiving Medicaid funds have in place delineation of privileges for addiction specialists, regardless of location. Because this doesn't mean that they necessarily have to have addiction specialists as staff, but that they have to provide a means to have them. Okay, that's simply adopting a protocol. Any hospital can do that, and quite frankly, some of these services can be provided via telemedicine, and so we could provide care in rural hospitals if this were to pass. Now, also for these delineation of privileges, I think it's important that we maintain a good standard. So I do believe that they should be certified by one of these boards. I believe we should provide a pathway for NPs and PAs, and there I have included the different certifications that exist for them. And finally, I believe peer recovery navigators also need a credentialing process for seeing patients in a hospital. And that's kind of dependent on each hospital accepting the Nevada certification board that already does exist. Any questions?
Yes.
Okay.
Okay.
Yeah, Leslie.
I'm trying to figure out where it is. Anyway, so it's Dr. Dixon for the record. Dr. Bertita Corona, have you, in regards to the addiction consult service, have you talked with anyone at the Valley system recently about this? Because I gave a talk to them the other day, and then I met with one of them. Actually, I met with the CEO. Anyway, and they're trying to get something going there. So I would check in with them and see how far along they are.
Okay, I would love to. I think the key point though is the adoption of these delineation of privileges, because like I said, right now, so much of that is grant funded, and those grants are in question right now, as far as whether they'll be there. So the number one thing, the low-lying fruit, if you will, is to open up the gates so that these services can be billed for in hospital. Because if they do that, then these fellowship programs too will have a means of generating their own income without having to be too dependent on grants. But yeah, I would love to speak to anyone that you know of in the Valley Health System. I'm sure Kelly Morgan has their ear as well.
I could add to that.
Huh?
And I could add to that if I may.
Sure.
I don't have camera on my monitor here, so apologize. Maureen Strom, I'm the program director for Nevada's first, and so far only, Addiction Medicine Fellowship in the state. And I very much appreciate having both Dr. Partida Corona as our first fellow and Dr. Dixon as a longstanding faculty member of virtually every program in the state. I've had some very good meetings myself a month or so ago with Valley Health Systems and separate from Valley Hospital in terms of their interest in moving forward with expanding their services. One of our fellow grads from last year has maintained a very close relationship with Valley Health Systems as she finished the family medicine residency there. And we've been in some discussions about what it might look like for them to start providing addiction consult services in their hospitals.
Beautiful.
Do we have any other questions or comments for Dr. Perdita Corona?
Yes, Chelsea Cheatham.
Yes, Chelsea.
Yes. Thank you for that presentation, Dr. Partida Corona. PACT Coalition for Safe and Drug-Free Communities, who's my employer, we currently have peer recovery support specialists that are working within Valley Health Systems. Right now, they are stationed at Valley Hospital in the emergency rooms, and they're meeting with patients on a daily basis, helping to navigate them into treatment. So you're 100% correct that it is a really good way to make it a low barrier entry for people to get into treatment when they're talking to someone who has that lived experience. I know that UMC Hospital had a program with Track B Exchange, Impact Exchange, and I believe they're trying to restart that program at UMC, but 100% we are open to talking to any organizations that are looking to place peers in hospitals and help them figure out like the best way to do it, because we've been able to do it with Valley Health Systems.
Out of curiosity, how is that being funded? Is it grant funded?
It is, yes, it's
Yeah.
great.
Yeah, and it's great that they're in there. Don't get me wrong, but I want to keep them in there, and I want to grow them. And that is why it's really about figuring out a different revenue source to maintain it. That's the trick.
Yes, I 100% agree with that.
Okay.
Dr. Perdita Corona, I had just a question or comment. I wanted to ask if you've had any discussions with Medicaid or the Division of Public and Behavioral Health regarding, possibly looking at the requirement of privileges.
I don't have an in, so
okay.
Yeah, if you could put me in front of some of those folks, I'd be more than happy to talk to them and why it's important. Yeah, that I don't have any problems with.
Okay, we can certainly work on that. Yes.
Okay.
And then I wanted to mention to you that UNR is launching their Addiction Medicine Fellowship in July of 26. So we've still got another year in Northern Nevada, but it is launching next summer.
Good.
Any other questions or comments for Dr. Perdita Corona?
I just have one thing, Dr. Perdita Corona, John Firestone. I'm one of the presenters, and I also work with a group called Nevada Opioid Treatment Association. I would love to have you at one of our meetings. I think it would be a great conversation to have with a larger group of opioid treatment providers in terms of the bridge program.
I would love to take part. If you would, you know what? I'm going to figure out how to send it on chat. My
email. Yeah, if you could just get me somehow your email, and then we can just start the conversation after the meeting.
Mr. Chair,
Yes.
since I secured both speakers, I would be happy to connect them with each other. Kelly Marshall, for the record.
Thank you, Kelly.
And anybody and everybody that wants to talk to me, by all means, there's my email.
Dr. Perdita Corona, thank you so much for your great presentation. We really appreciate you being here today. Look forward to continuing to work with you.
Appreciate it. Take care.
Thank you all. Thank you. Okay, moving on to item number 5 in our agenda. Next, we have John Firestone with us. He is Executive Director of the Life Change Center, and he is going to present on CFR 42 Part 8 Final Rule, Patient Care First. So very excited to have John with us here today. So hello, John. I will turn it over to you.
Thank you, Steve. I appreciate it. And thank everybody for inviting me on here. I really am appreciative. And Dr. Kearns, I know she's not here, but I have a lot of thanks to her, the work that she's been doing. We've been impacted positively. So you guys doing good work too. I read your 2024 report. I thought it was really, really good. There's going to be thanks throughout my presentation on different points. So a couple things I didn't come really to talk about the Life Change Center. I do work at the Life Change Center. I've been working in the field of opioid use disorder for 25 years, and 20 of those years I've been at this company, the Life Change Center. But I'm also have the privilege to work as the president of the Nevada Opioid Treatment Association. I'd really like to speak more from that perspective in this presentation. One other thing about me is I'm also an accreditation surveyor for a group called CARF International. I don't know if anybody's heard of that, but they do accreditation for outpatient facilities. And that's given me some really great insight too, because I've been to OTP, opioid treatment programs, nearly 200 of them in 44 states. And it's been helpful to see what other folks are doing. So if I can get you to go to the next slide. Oh, there it is again. No, disclosures are interesting as an opioid treatment association. We have 14 individual sites within our association, and the funding that they all receive vary from facility to facility. So there's a lot of different financial interests based on their funding source. A lot of the opioid treatment programs within the Nevada Opioid Treatment Association, I'm just going to call it NOTA. So before I continue, let me give a big apology for just a probably overuse of acronyms, but we'll get through it, and I apologize up front for that. But the NOTA programs, most of them are Medicaid, Medicare, not all. Most are private insurance, and some have grants. About the Nevada Opioid Treatment Association, as I mentioned before, the last 2 years, I've been able to work as their president. It's been a really great opportunity. You can read the mission, and you can see that there's 7 different providers. There's actually 8, and it's not that we have any challenge getting NAFCare on board with our Nevada Opioid Treatment Association. They're just busy. It's a very difficult system for them to attend meetings. We talk with Maggie up in the north constantly. We work very well with them, and they're doing excellent work. But you can see the list below of the different groups that are running opioid treatment programs. And they vary. Acadia has 3, Behavioral Health Group has 4, Life Change Center has 3. A lot of them are just individual. So there's a total of 14 within our system. And within that group of providers, they're giving services to about 4,500 people a day. So if we can go to the next slide. And I'm guessing I'm going to be telling you things that you already know, but I'd like to go into the opioid treatment programs, what's actually happening there. I refer to them as a crisis stabilization hub. I know that word has a lot of different meanings. For me, I'm talking about crises related to opioid use, and people do come to us in a state of crises. The programs, the OTPs, act as a hub. So all OTPs have the capacity to triage and refer if necessary, or provide services that they would have in-house. And the primary services at all OTP is going to be MOUD dispensing. So the difference is that OTPs use methadone and buprenorphine and a variety of buprenorphine products that are managed in a fairly secure setting. And it's a really good setting. A lot of the people that come in to see us may not be able to manage medications well on their own. So we're able to help them get to a point of stability and watch and extend the prescription, if you will, or the take-home privileges as people are doing better and better in treatment. But also, I mentioned before, there's substance use disorder treatment at each facility, case management, Narcan is common at all facilities, and as well as outreach and community education. Some of our facilities, and I would say a majority of the opioid treatment programs, have psychiatric and behavioral care on site. A few, including the one that I work for, have robust peer recovery support systems. I heard somebody mention Track B earlier. So Track B is also working with multiple of the opioid treatment programs within the state. And a few work specifically with family programs, and that would include the Life Change Center. And that's pregnancy, neonatal programming. And then there's a variety of different opportunities. It's kind of a cool opportunity for us. There's a good intersection between the needs of a family and the services that are provided in an opioid treatment setting, because a lot of the people we're meeting really don't have I don't know if the trust might be part of it, or the bandwidth in other areas to engage with other form of family programming. If we can provide it on site, they tend to already trust us or one of the noted members, and we have better access to prevention activities with their kids. So yeah, you can move on to the next one. So within the special populations, I've read what you have. A lot of them line up with what we see in the OTPs. And I mentioned those here. Interestingly enough, people who inject drugs is becoming less and less common, with fentanyl really being the drug of choice, or at least the most available form of opioid out on the street. That is primarily smoked. You do not see as much with the injection. So we do have harm reduction supplies going out, and the needles that are being used are primarily with stimulants, methamphetamine. So we're getting kind of an intersection between those two substances too. I mentioned earlier that pregnant women, like the Life Change Center, for example, will range between 30 to maybe as high as 60 successful pregnancies in a year. Depending on the year, it's never quite the same. We do work with people that are coming out of the criminal justice system, a lot of work depending on the agency, with veterans, LGBTQ communities. Not much. You did mention child welfare system. We don't deal with that much. Primarily when we're dealing with that is when we're working with a parent that may have a child within the welfare system. One of the big ones that was not mentioned in this one, but last year it was people with co-occurring diagnoses. That's a fairly large percentage of the folks we work with. So if you want to move on to the next slide. I want to talk a little bit. I don't love the title I came up with, so I'm going to change it up. It's really more about the people that are being given services. So I mentioned that we have 4,500 people a day receiving services, but that can encompass a lot of people that are already stable. They could be on a maintenance sort of medication. And that's one of the benefits of an OTP also, is we can keep providing methadone or Suboxone to people over time. And they're doing quite well. When we meet people for the first time, and it's hundreds of intakes a month, there's a lot of problems that they're facing. Like there's a low level of protective factors and a lot of risk factors that they're facing. Homelessness can be a problem. Certainly a majority of the people that come to OTP for the first time are unemployed, which makes it, there's a lot of work that people have to do when we first start with them. There's usually deferred health care. There's usually deferred mental health care. There's deferred dental care. So we're really working with people that need a lot of services. And to no great surprise, over 65% of the patients that are in one of the NOTA OTPs are on Medicaid, or will start them on Medicaid when we first meet them. And if we can keep them in treatment, they do well. Stability is when a patient has been in treatment for 60 days, and we're not saying that they have to have done perfectly within 60 days, but the data I'm going to share is referring to all people that have not discharged within that first 60-day period. So likely they're taking medication more days than not. Likely they're meeting with a counselor or some other form of a service provider, maybe a peer recovery support provider or mental health. Within that group, about 70% or more, usually higher, have achieved their goals of sobriety, which is no other substances within their drug tests except for those that are being prescribed. and a larger number have discontinued fentanyl. And that's something that we take a lot of pride in, because fentanyl has really changed the landscape of what we do. Of that group, about 40%, sometimes higher, sometimes lower, but about 40% are caretakers of children under the age of 18. And this is one of the reasons we see those development of family programs. And people that get involved with an OTP are much less likely to die of an overdose. We rarely have people in treatment. If I could have you go back just 1 second. Rarely have people would die of an overdose. And this is based off CDC data and some other data that we got, because there's a difference. The people that we provide services to are always moderate to severe in their diagnostic category of opioid use disorder. Most of your CDC data will include mild and any misuse. So there are some data that show the moderate to severe. So it's actually more than double that, but that's there is a big safety factor with OTP. So now, I'm sorry, now we can go on to the next one. I'm calling it patient care first because I was corrected. Some of my partners in NODA, I said, well, we're kind of a medication first model. I said, no, we're a patient care first. Okay. So I want to talk about CFR Part 8 final rule and how that's impacted what we can do. So the first thing I want to talk about is intake. Previously, an intake would take between 2 and 3 hours. A patient would come in, they've got to fill in a lot of forms that would be disclosures and mandatory just forms to get a person engaged into treatment. Then they would meet with a behavioral health person, most likely a substance use disorder counselor. They would meet with a peer recovery support person who would talk to them about Narcan and introduce themselves. They would likely meet with a nurse and then finally a doctor. And the doctor would do a physical assessment of them and likely write a prescription for them to start in with the program. They would get medication the same day they showed up in most cases. Once again, that's 2 to 3 hours. With the SAMHSA changes, the CFR Part 8 final rule allows for us to divide that in half. So now when a person comes into an OTP, we're able to focus primarily on the medication, if not solely on the medication. It allows the parts of that to come later. In particular, the behavioral health component is very, very mild when we first meet a person. In today's intakes, it takes about an hour and 15 minutes, an hour perhaps, to get a person in and on a medication when they stop in an OTP. And then we'll meet with them again in 14 days to finish the rest of it. So for example, we have quite a large biopsychosocial assessment that we do. It makes sense. You want to get a person stable before we start asking them this long list of questions. So I really love what they've done. Allowing us to break it up makes it easier. It makes it easier on the patient. And it just makes more sense because we can do some of these more complex interviews when a person's in a better state of mind. The other thing it allows us to do is a higher initial dose level. So methadone and buprenorphine products do differ, and they're not all the same in how CFR Part 8 has affected it. Methadone in particular, there were some limits to what we can start a patient on. And with the onset of fentanyl, we were seeing that was just too low. It was not set, meeting the needs of a patient's withdrawal. With the new levels, they let us go up a little higher on initial dose and let us go up higher in the first week, perhaps, or more. That's all a doctor call. It works really well. Our retention has gone up substantially across the state based on this. The other thing that's a carryover from the COVID rules, there was relaxed rules about take-home medication. What they found in that process is that methadone was not nearly as dangerous as had been talked about before. So they've really allowed expedited access to take-home medication. So in the past, a patient would have to come in for maybe 90 days before they start to get take-home medication. We have the ability to give that almost right away now, but different programs have different policies that they've developed. But for the most part, it's easier for a person that starts on an MOUD to have less time at the clinic, more time at home, and hopefully they're doing well in the other areas. OTPs are kind of like a gym. like a recovery health gym. Nobody has to be there. They just show up on their own accord. So we try and get people to engage as we can with other services like counseling. That's a part of it. The last piece, which has been a really blessing too, which is the expansion of virtual services, including intake. So using the company that I work for, we have 3 clinics. I can have a doctor on staff in Carson City, and as patients come into Reno and come into Sparks, we can do virtual intakes there too. It works quite well. It's allowed us to have much broader intake schedule than we've ever had before, cost effectively. So here is the problem. So OTPs in Nevada are chronically underfunded. What you're looking at is your Medicaid reimbursement rates that have been generated on a weekly average. Arizona and Nevada are the lowest by far. The rates for medication administration in Nevada have not changed since 1980, which is a lot has changed since 1980 in costs. So all OTPs lose money on all Medicaid patients. And 65% of the people that come in are Medicaid. And what this makes a challenge is staffing. The biggest challenge to increased access that OTPs face and our state faces, perhaps for the safety of their citizens around fentanyl, is we can't grow past our staff. At one point, we max out. You can't just keep bringing people in, and we can't afford to increase our staff until we can get those rates up. It is one of the biggest challenges, and this is fairly recent. It's from 2023. I don't know how much has changed. I know like Idaho's not on there. They're on there now. What we're seeing is most states that start to adopt rates for medication dispensing, it's meeting somewhere towards the higher end. So I think a lot of states that are lower, like Oregon, it's because they developed these policies quite a while ago, and they're around $8 a day, where Nevada's at $3.90. So that is the problem. So the recommendation, if we can increase reimbursement rates for the administration of medications, we're going to see more people come in. There has not been any new OTPs in our state since the Life Change Center opened their last 2, and we're a nonprofit, and that's the only reason we can do it. Nobody will come to our state, period. It just doesn't make sense. They're going to lose money. Until we can correct that, we're going to have somewhat of a gap in the amount of services that we have and those that are needed by the drug-using community. Not an easy thing to accomplish in today's world, but that's what we need. I can tell you that there is a bill, I'm not totally certain about what it is, that's out there right now. They're looking at it. I'm very hopeful that that will happen. And over time, this will allow us to increase not only the services on the 14 clinics in our state, but also to bring in some new people from other states to come in and start practicing here. The other is to increase outreach to reduce stigma. That's still an issue. I have to admit that it's so much better now. I've been doing this for so long. It is way better today than it has been, but there's still a lot of work to do. There is so much work that we have to do, and it's all a matter of outreach. It's hard to do outreach when you're chronically underfunded. It is, I'll be honest with you, the grants really help for those that receive them, but not everybody does. You have done some great work. I put thank you in there. I read that you were involved with recommendations to drop the tenure since your last conviction from 5 to 3 years was a recommendation. I just want to thank you for that. We've bumped into that recently with Medicaid has changed in our areas, now called Provider Type 93. And with that, we have not been able to credential many peer recovery supports because of their criminal history. We're working on it. Everybody's aware of it. SURG, I want to thank you for the work that you've done to get that reduced. But this is something that we need to work on. And Dr. Partita Corona, this kind of speaks to what you were talking about. If we can get, there is currently a Provider Type 97 being proposed. in the new provider type 93, it's a 97, but it's with the same model. And they do have specific payments for peer recovery support specialists. The last one is the hardest one, is how we can increase access to MOUD in rural communities. This is likely going to be primarily buprenorphine based. If there's a way we could do it, I think we would have done it by now. To start an OTP that can dispense methadone is fairly costly. It's generally brick and mortar. There's definitely some efforts out there to try and get more mobile treatment centers, for lack of a better term. But what I've seen nationally is those vans that people design for MOUD is primarily for intake. So you don't really see yet develop vans that go into a rural community that can distribute MOUD. If it is, it's very small numbers. Most of the vans that are being used are like in large cities, and they'll do it mainly for intake to get people started. So if you go to the next slide, please, that's my acronyms. So are there any questions for me about NODA or the opioid treatment program community?
Do we have any questions or comments for John today?
Yeah. Yes, I do.
Yes,
well,
Dr. Dixon.
I just sent an email off to our lobbyists. I think the bill for increasing the Medicaid rate went somewhere, but it may be stuck in one of those finance committees.
It is, yeah. I don't know enough about it to really do it any justice, but I think you're right. I talked to, and you're with BHG, is that correct?
Yes.
Thank you for
But
your
I'm
work,
also
by the way.
I'm also with the NPA, and I'm at this point looking for the NPA's lobbyist
Oh,
to try
okay.
to see what she knows. She follows things very closely.
Yeah, if that would be great. If you could find out, please let me know. I've been kind of, just operating on faith that that'll go through, but one never knows. It is a difficult time.
Anyone else have any questions or comments for John?
Yes, thank you so much for your presentation, John. This is Dr. Strom again.
Hi, Dr.
I
Strom.
am really excited to have my current fellows in discussion with WestCare, who have received grant funding to do just your last bullet point there on getting mobile vans out into the rural areas. And they're actually looking at it as a way to initiate and continue methadone treatment. The rules have expanded also in terms of the take homes, so it's not as restrictive as our previous ones, but as well as buprenorphine.
So I can introduce you to, let's try and get our emails shared. I know a few groups that have, one's in Chicago and one's in Seattle. The group in Seattle in particular, very easy to work with, and it might be of help to talk to them.
Very good. Thank you so much. And I'll reach out to Kelly to get our emails connected.
Okay, thank you.
I see Dr. Pardita Corona with his hand raised.
Yeah, one of the things that I was thinking was that perhaps we could get a letter writing campaign with a few of these things, like the provider type 97, like a bump in the reimbursement for methadone, because I think we can all agree that those are things that our community needs. But I think by us all reaching out simultaneously, then the powers that be will realize just how important it is within our community.
That would be amazing. I think it would take some quick organization to take advantage of a bill that's currently out. We're really heavily into that process. I think it's gone into some sort of a silent mode where we're waiting to see how they actually voted on it. So, but it would be amazing. Again, I think one of the things that would be beneficial for you in particular, Dr. Pardita Corona, is to come to one of our meetings and let's just start a more of an in-depth dialogue about how we can work together. One thing that's been really a joy for me is, like, even though we're underfunded with this fentanyl problem, the OTPs have unified really, really well. I mean, they're working together. So we have representatives from every group there when you show up. And most of them are in the South, which makes sense. There's just not as many people in the North. But yeah, you'll have good access.
I'd be glad to join.
John, we really appreciate your great presentation today. Really glad that you could be here with us today.
Oh, thank you, Steve.
And we look forward to continuing to work with you, John. Thank
All
you.
right. All right. Thank you.
Thank
Oh,
you.
hey, I got the answer.
Oh, yes, Dr. Dixon.
The answer is not yet. And the bill is a phased in increase up to $15 by 2027.
Yes. Did they say it
Right.
did they say it got approved?
No, it's she said not yet, so which means it's probably in a finance or budget related situation, because pretty much all the bills got out of their last committee on Friday. So there's not much left to do, but just wait, you know.
I
and
know the waiting's killing me.
Yeah. And if you know, if I don't know, see, I don't know where it started. It started in the Assembly or the Senate, but
It was SB. It was, yeah.
SB, it might be worth writing to, so it's probably stuck in Senate Finance.
What I
raise-
found is like we're working with MDL primarily and Rochelle Wynn, but they're so busy. Like yeah. So we have to be very tactful about how much like contact we have with them right now. I think what we've all decided is just to let them do their job. And I'm just eager to hear. It would be nice if we could correct this long-lasting problem. I think we could, yeah.
It would make a big difference, that's for sure. One of the things that Dr. Kaiser and I are doing with the buprenorphine patients is, you know, the original recommendation was that you see patients once a month, stable patients, and not give refills. Well, we decided that that's ridiculous, and so we do refills and see them every 2 months, because a lot of our patients are cash pay, the buprenorphine patients, and it's just really hard on them. So with a change in the waiver program situation a year or so ago, they're really not paying that, you know, they're not really enforcing all these guidelines anymore. So that is one thing that is helping, I think, a little bit with the financial stress on the patients.
Yes, I agree.
Well, Dr. Dixon, thank you for following up on that bill. And John, thank you again for being here today. We really appreciate it.
Thank you.
Thank you. Okay, so
mind if I
moving on
hang
to
out for
item
your
number
meeting?
6. I'm sorry.
Do you mind if I hang out for your meeting?
Yes, you're welcome to stay for the rest of the meeting, John. Yes. Thank you. So item number 6 on our agenda is a review of the progress on our prior recommendations from our committee to the full SURG. I know several of us in our past couple of meetings have been talking about the progress we've made on some of our recommendations over the last few years. So I know Laura Hale with SEI graciously volunteered to research the progress, and I'm going to turn it over to Laura now. So hello, Laura.
Thank you, Mr. Chair, and I'm going to try to share my screen here and bring up that document. Can everybody see that okay?
Yes, Laura.
Great. So several weeks ago, the Jessica Johnson with the Prevention Subcommittee asked for updates on the recommendations. And so we did them for all of the subcommittees. This particular document is just in draft form, but we will be updating these to get everything all together. But for this document, it just has the treatment and recommendations. I'm sorry, treatment and recovery recommendations. And then some of them cross over multiple subcommittees. So I'll share some of those with you too. And So this first one, because it was just came forward in 2024 and was talking about legislation, the timing was a little bit off. So just so folks know, and some of you may already know, when you're asking for a bill draft request to be submitted, the state agencies need almost a 2-year time lead in order to do that, because they have to get all of the approvals internally through their divisions and through their department, and then it goes on to the budget administration, and then it goes on to the governor. And so it's a very long process to get those authorized. So just something to keep in mind. So on this first one, and I know this did come up earlier in your discussion about the PRSS and the felony backgrounds and trying to get timeframes around that. So we hope to bring some more assistance in doing that when we meet with the full surge in July. And so hopefully more information to come. But at this point in time, we don't have particular updates either from the Department of Health and Human Services or in terms of legislation. For the BDR 95, which became AB 394. I'm sure a lot of you know that did get amended and did pass in April through the Assembly, and then in May through the Senate. And I know Ms. Edwards certainly knows a lot more about that than me. So if Ms. Edwards wants to comment on that.
I think you're doing a great job, Laura.
Oh, okay. Well,
I don't have much to add, unfortunately, on that one.
Yeah, so the amendment is written there about they changed it to be the lowest dosage effective to restore breathing instead of what was originally put forward. And then you also had several legislators join as joint sponsors. So this was a very popular bill.
It was, yeah.
And then on the next one down for the bridge program, which was part of the discussion today, I just wanted to let you know, Dr. Morgan, who previously presented to this subcommittee, did present in May to the prevention group as well. And she had one of the ER folks from California where they're allowed to provide that service in the ER. He presented how they do it. And so there's a lot of people looking at this, and hopefully next time around that can get moving forward. On the next page down here, expand access to math. So this was a 2023 recommendation. We got a lot of information from the Department of Health and Human Services, and specifically, let's see. Brianne Van Dyne very graciously provided us all this information on pretty short notice. She is with the Bureau of Behavioral Health, Wellness, and Prevention, and there are all kinds of grants under the state opioid response program that have gone out that are working on some of these. And it's not always an exact match to what the recommendation was, but it's very much related. So you can see all of these things that are listed here as 5, 7, 25. Those were the updates that I just got from Brianne about all these different grants that are going out for MAT treatment or something related. Also, there is this bill that went in the current session, AB 380, to revise the composition of mobile crisis teams and people who would be professionally qualified in the field of behavioral health, one or more law enforcement officers, providers of EMS, people with expertise in behavioral health, including community health workers, case managers, peer recovery support specialists, or similar professionals. That bill also passed through both the Assembly and the Senate. And then you can see down here, these are just some more grants that are going out that are related to that particular recommendation. And I will tell you that the treatment and recovery group, far more than prevention and response, has a lot of activity because there are grants that go out specifically for treatment. And, you know, whereas in the other cases where it might be more oriented to a bill draft request or a SPA, perhaps, with state Medicaid, that's a state plan amendment, or if it's a budget request, for sure, those things take a lot longer because there is a very long lead time to make those kind of changes through, you know, either a legislative or a regulatory or sometimes federal regulatory process. So just something to be aware of. These are older activities that were reported to us back in October by that same bureau. And then also, in this case, Medicaid had done some work on this stuff. And then the next, this is another 2023 recommendation. You can see there are some more grants there. And there was also legislation in 2023 related to this. And you may recall that Bill Teal did present to the SURG in 2024. He will be presenting again in 2025. I think that's scheduled for late summer or early fall. And then here again, just multiple grants that have gone out. Sometimes they're under the state opioid response grants. Sometimes it can be other programs, including Medicaid. So lots of activity going on there. Here are some more 2023 grants that are recommendations that have current grants and as well as older activities related. So really there's just quite a lot of activity that does occur, and just depending on the timing of it, sometimes it's easier for us to get that information out to the SURG members. I won't go through all the details on all of these. So this next section down here, I mentioned earlier that there are some recommendations that cross over different subcommittees for the SURG. So this particular one that I did report there has been some progress on. That was also something that came up under harm reduction in 2023, and there was some activity related there. So once we get all of these finalized with all of the subcommittee related activities, we'll make that available as a final document, but it is just kind of a draft for now. But you can see there are some others here that cut across, you know, this one from 2024, access and linkage for treatment of trauma for people with substance use disorder. That was similar to 2023 harm reduction recommendation. And again, you can see there were some related grants to that. Some places that are offering grief counseling, which has come up many times with the SURG. And that's the end of that particular document. I also posted a document online, and I don't know if we have time or not, Mr. Chair, but it has some of the bills that we're tracking for the SURG that have various activities. And of course, it's changing all the time, but I can go through some of that now, or if you prefer to move on to the next item, I can, we'll have these all updated for all of the SURG members in July.
We are running short on time, Laura. I would love for you to be able to present that, but if you could let us know, where is that posted, Laura?
So it's on the AG's website. Let me see if I can go back there. Yeah, so if you just go to that website where we post everything, there's the PowerPoint. So this one that says related bill status, and that has, you know, just this is a point in time, so it's not final, but you know, some bills are making their way through pretty well. So.
And Laura, if it would be okay, maybe at our next meeting in June, we could even, you know, of course, the session will be ended by then, we think, but maybe we could even go through some of that in our next meeting, if that's okay with you.
Sure, sure.
Okay.
Yeah, at the committee's and the chair's pleasure, yes.
Okay.
And I will stop sharing and give it back to Kelly.
Kelly, did you have anything to add to Laura's presentation?
Thank you, Mr. Chair. Kelly Marshall, for the record, I did not.
Okay.
And I am just trying to rejoin our slideshow here.
Any questions though, or comments for Laura from any of our committee members? Laura, this was great information. We really appreciate you pulling all of this together. So thank you. We'll look forward to going through the rest of the information with you. So thank you.
You're very welcome.
So moving on to item number 7 on our agenda, this is a review of the 2025 Treatment and Recovery Subcommittee meeting topics. This is for discussion only. We do have 3 topics at this time that you see on the screen there. The first one from Dr. Kamyar with Rosamond University to present on current trends in substance misuse treatment. The second one there is a proposed recommendation from our own committee member, subcommittee member, Chelsea Cheatham. This is on retrospective assessment and/or prospective study to assess the outcomes of patients following discharge from detoxification and examine mortality and overdose. And then the third topic there is from John Hamilton to present.
So,
I'm not
Mr.
sure.
Chair, just
Yes, Kelly.
if I may clarify, Kelly Marshall for the record. So Dr. Kamyar was originally scheduled to co-present along with our 2 presenters today, but that was when the meeting was scheduled for the 20th. When we had to reschedule, he was not able to attend today. So he has confirmed that he will attend or that he will present. And we wanted to, one, validate that we had everybody available and could reach quorum in June to keep that meeting, and then we will schedule him for that. So that's a topic that you can see further on down on this slide, is that we can get to a discussion of who will be able to attend in June and make sure that we'll have a quorum. And if so, then we will ensure that Dr. Kamyar is there. Then the second topic was a proposed recommendation from Chelsea Cheatham. And she, as part of her proposed recommendation, suggested a proposed presenter. And so I think the question is whether this group would, if we're moving forward with the June meeting, or if not, if we're waiting until August, would they like that presentation from Mr. Hamilton? And Ms. Cheatham's recommendation shows up on this presentation in about 2 slides so that people could see what that is around.
So Kelly, on that note, let me just ask, do we have any committee members at this point that are not thinking they will make the June 17th meeting? That date works for me, but I want to make sure Kelly and I want to make sure it works for all of the other subcommittee members. So is there anyone on our subcommittee who won't be able to attend June 17th? Okay, Kelly, so that sounds good. That it sounds like we'll have a quorum in June and we'll be able to move forward with these topics here. Now, on that note, do any of our committee members have any other recommendations for presentations for upcoming meetings? Okay, and then Kelly has just posted the survey link for recommendations, and I'm going to own it for myself that I haven't submitted my own recommendation yet. So you still have time to get your recommendations in. Mine will definitely be in before the June meeting. But we just wanted to remind everyone to please submit at least one recommendation. That was the ask of all of us on the full SURG committee, is to at least, make one recommendation. You can certainly make as many as you'd like, but at least one. So that's just a friendly reminder to go to the link there that Kelly has provided.
And Mr. Chair, if I may, Kelly Marshall for the record. I just wanted to note that the other subcommittees, as they are examining Ms. Hale's presentations on what has happened with previous recommendations. Some of them are considering resubmitting recommendations that perhaps have not had movement or traction. And so internally, we're having discussions among the support team for the SURG around what that would look like. And there is a larger presentation and review of that will happen at the June meeting, so that we can have a discussion in June about, now that legislative session is over and we know what the results are, we will know that by June, what this subcommittee's preferences related to. Do they want to take existing recommendations and resubmit in some way, potentially refining them, potentially updating research or the data supporting them, versus submitting new? And so I just wanted to note that other subcommittee chairs have even assigned homework, which is for people to research their recommendations and review the status that Ms. Hale has provided, and come prepared with some suggestions at the June subcommittee meeting about which recommendations they may want to resubmit. So that being said, as I mentioned, Ms. Cheatham has submitted a recommendation, and other subcommittee members may want to refresh and resubmit a previous recommendation or submit new. The final thing I would note is that for both presentations today, as is our practice, presenters are asked to make recommendations for consideration for the SURG. And so I would just call the Treatment and Recovery Subcommittee members' attention to the recommendations that both of our presenters provided. And their presentations will be posted on the Attorney General's website if people would like to go back and look at those recommendations again.
Thank you for clarifying all that, Kelly. And I'm so glad you made the point that we, can certainly revisit previous recommendations and recommend those again if the committee agrees. So yes, like you said, Kelly, I would encourage all of our subcommittee members to please review the information that Laura presented prior to our June 17th meeting, and come prepared to that meeting to discuss any of those recommendations that any of you think we should consider, moving forward or recommending again. Okay, any other discussion on item number 7 from anyone? Okay,
Yeah.
moving on to item number 8.
Mr. Chair,
Yes, Kelly.
Dr. Dixon.
Oh, yes, Dr. Dixon, I'm sorry. I'll turn it over
I
to
can
you.
never find I can't find the hand thing. Anyway, so reading the minutes from last meeting, I noticed that we had talked a little bit about HIDA. And so did we look into seeing if we could get the fellow from HIDA to talk to us?
Dr. Dixon, Kelly Marshall for the record. My understanding is that a presentation by HIDA is being planned for the full SURG in July,
Oh, okay.
rather than
Oh,
just
good.
treatment and recovery.
Right, because when they were talking about when Dr. Partita Corona, I guess, was talking about the overdose deaths, I had asked, I asked him, the HIDA fellow, about that. And one of the things they think is really the distribution of the drug, is that they're just not getting the fentanyl back east as effectively as they are out here. So it'll be real interesting to hear what he has to say.
So, Mr. Chair, I believe that we are working to get that scheduled for the July full SURG meeting.
Okay, very good, Kelly. Thank you. And thank you for bringing that up, Dr. Dixon.
Yeah.
So item number 8 is for discussion only. This is a discussion of our recommendations process and any proposed recommendations. And as we just mentioned, Chelsea Cheatham has brought forward a recommendation. So Chelsea, can I turn it over to you to to give us a brief overview of your recommendation? Chelsea, are you still with us? Kelly, I'm not seeing that she's still with us.
Yeah, I don't see her on.
Okay, so Chelsea may have had to leave our meeting, but as we said a few minutes ago, we do have this listed as a topic for presentation at our June 17th meeting. So more to come on Chelsea's recommendation, but we do thank her for being our first subcommittee member to bring forward a recommendation. So hats off to Chelsea on that. Okay, moving on to item number 9, we have public comment again. This is discussion only. Please bear with me as I make a brief statement. Public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter may not comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241010. So on that note, do we have anyone wishing to make public comment? I do see Dr. Terry Kearns with her hand raised. Hello, Dr. Kearns.
Hi, thank you, Chair Shell. I just wanted to highlight to everyone on the call that the Southern Nevada Substance Misuse and Overdose Prevention Summit will be taking place on Thursday, August 14th from 8 a.m. to 5 p.m. here in Las Vegas at the UNLV Strip Pavilion. The registration fee is $25 per person, but there are scholarships where that fee can be waived. And the registration is currently open, and there's also a call for workshops, and the call for workshop submission is due by June 1st. And those workshops fall under the 4 pillars of prevention, treatment, recovery, and rescue. And I can just in the chat, if you like, submit the link for registering or for submitting for workshop proposals.
Great. Thank you so much for that information, Dr. Kearns. Anyone else wishing to make a comment? Okay, seeing none, we will move on to item number 10, which is adjournment. Before we adjourn, I just want to remind everyone our next meeting is on June 17th. So we will look forward to seeing everyone then. And in the meantime, please take care and we will adjourn this meeting. Thank you all for being here.